Well, here's a couple of things that you can think about. Here's something I prepared earlier. So here you've got the simple situation where the lesion sits on the mucosa. Your scope approach is very good, and I'm going to tell you now, you should have in your department a 4mm needle, which will be somewhere between the 23 and 26 gauge. If your needle is longer than this, it's too long. You're going to push it straight through into the peritoneum. And if the scope, if the needle diameter is any fatter than this, so it's 21. I'll just talk a little bit about pedunculated polyps. We saw the loop here, and I was talking about coaptation, and you might not know what that is. But here's a typical pedunculated lesion, and what we're interested in fact, is the let me just see. What we're interested in is the stalk and what lies within the stalk, and what lies within the stalk, obviously, is a vessel. Right, and the fat of the stalk, probably the fat of the vessel, particularly if it is a sin.
John, have you got some comment on that?
What?
I think the key thing here, David, is risk and benefit to the patient in context with all the factors. And as therapeutic endoscopists, and I am guilty of this myself, my eyes are on the prize, and the prize is usually the lesion, and I have to steel myself to see the wider picture. And that's why I think MDT discussion is really important. I think it's pre-assessment is really important. And sometimes doing nothing might be in the patient's best interests. And that conclusion needs to be reached through multidisciplinary discussion. If you are the sole person making those decisions, then you must be aware of what the factors are and balance the risks.
Yeah, and I think it's critical discussion with the patient, isn't it? Yeah. There's a couple of things stopping you being able to do that. Suction is one thing that's going to really help you. So it's way too distended. So we can really just sit on the suction more, much more. Go. Okay, look at that. Already it's better. To do it more, I would. Okay, now try and use the small wheel to pin the polyp down and up, down as well. Like really pin it down, but that's not good enough yet, I think. Although it's much better. Okay, a little bit less if you can. And now suction more. Push out. Really naturally you're pushing out. That's great. Suction more. More. Okay, that's starting to look good, Clemente.
Okay.
Yep.
So I think it's okay to close the loop. Okay, close.
So we'll leave anything small like that, because this is 2mm, isn't it? 2 maximum, 2 I would say.
Okay.
2 or 3. We know there are more, that's for sure. You can often take a pragmatic approach. What do people in the seminar room think, Lynn, about leaving these polyps here in the context of this?
I think it's all right to leave that small polyp in. Yeah. Especially because he has pancreatic carcinoma, you really have to respect it.
Yeah, I mean, I think that's the key point, isn't it? Yeah. Suction there. Any other questions from the seminar room while we're going back? Just looking at all these nice little adenomas that we'll leave in place.
How long will it take until such a small adenoma can become something bigger or pre?
Great question. I'm not sure we know the answer to that exactly, but we're talking 10 years, aren't we, John?
Yeah, the consensus is 10 to 20 years for a small adenoma. For a sessile serrated lesion with dysplastic change or adenoma formation in it, it's considerably less, maybe in the order of 2 to 3 years. So it has a much more accelerated pathway when it's present within a sessile serrated lesion.
So actually, when you leave a small adenoma like that in place, you have to do a new colonoscopy in 10 years anyway.
I don't think leaving these lesions in place in people who are not who have got a normal life expectancy. Absolutely not. As in, they're going to live more than 10 years. We're not going to leave them in place. But in this case, this is clearly a different situation. I very much like what I'm seeing here, Commenti. I think you could leave the scope on the bed a bit more and, you know, let it a bit more relaxed, but that's something we could talk about your colonoscopy technique. But I really like how meticulous you're being, suctioning, checking everything. You could maybe distend a little bit more so that you can see more of the colon. Because I feel that there's just maybe too many folds in the way, and the way to get around that is just keep on putting in CO2. You're using the cap nicely already, which is great. Okay. So we'll polyp there. So I'm conscious that we need to give Jean a chance. So yeah. Why don't we give the scope to John now? Just make sure it's stable when you give it, so that she has a chance of maintaining the position. And then we go back.
Okay.
Is the bed too high for you, or is it okay?
No, it's okay.
All right.
So it's a small polyp.
It is small, that's for sure.
Yeah.
Let's pretend it's over 3. It's probably not.
But it's difficult position. It's on
yeah.
the fold.
It's right on a fold.
Yeah.
So what did
And
you
I
see
think-
Commenti do with a bit of prompting that made it possible for her to get the snare around a polyp in a very similar situation to
Yeah.
this?
Okay.
What did she do?
So first she put it on 6 o'clock.
Right.
So that's here,
okay. Yeah.
And then she put some pressure.
Okay.
on
So
it.
let's try that. Let's get the snare and let's try doing that. And the other key thing she did was suction, right? So when the snare was on it, then she used suction very effectively while controlling the snare position. But I think here, if this is difficult, we could try injection to get it more.
Okay, you can open it.
Okay, so now will be the time either to push it out and pin it down, to push out the snare catheter around. I've got the scope if you want. Yeah, I've got it. But yeah, so that's great.
Okay.
It's already great to do that.
Okay, so I think the position is now good. I just don't. Yeah. Okay. So now a little bit of suction.
I'll just close. Wait. You're losing the margin here. So that is a classic example of trying to make something perfect when it already was. That is now quite good. Okay, so now.
Yeah.
Yep.
So I think we can close it.
Yeah. Perfect. Okay. So you didn't say close to him, cut to him. So you were kind of pulling on it, but you have to say cut.
Yeah, sorry.
Maybe not where you work, but here, here, I'm asking for waiting until then. Okay, so let's have a look at the base and suck up the polyp. That was very nice. I think that you were demonstrating that you really wanted to get it 100% right. Maybe you need to take the snare out because in most scopes, in the adult scopes, you can suck polyps past the snare. But in the pediatric scope, you have to be more careful.
It's looking good.
I think it's looking very good. All right. Well done. Let's come back and find another one, shall we? Show us a bit of your withdrawal technique and how you're doing it. You have got the scope on the bed, which I like. Just think about Commenti. Look at her scope on the bed and think about what, in a minute, we'll look at the video. Think about what you would do.
Okay.
But it's not because it's bad, like you can do it, but your whole ergonomics will be better.